Hello, my name is Dr. Talha. I am currently working in Nottingham University Hospital at a trust grade SHO in surgical department. Today we have a very interesting lecture. It's on liver and transplant. I have specialty registrar Mr. Aamir Nawaz with me today. So first of all, thank you because he has done 4 transplants last night, and he came back home in the morning, and he basically we have not let him sleep. So thank you so much for joining us today. So before wasting any more time, over to you, Mr. Ahmed.
Okay, thank you very much, everyone. Thank you, everyone, for joining. Um, hopefully, I will be. You can see me, and hopefully, I'm. Thank you, everyone, for joining. Um, so, I'm. This is a lecture on behalf of Kemka UK. They have initiated this program of MRCS teachings, multiple series of some lectures. So it's basically focused on MRCSA. When I did MRCSA, it was quite a few years back, some years back actually. So, what I've seen through the curriculum, and I think my specialty is very specialized. It has a lot of things, quite complicated. So, I've tried to gather some important slides which will be helpful for all the students or the people who will be um, taking MRCSA. So, as Salah has kindly introduced me, my name is Aamir Nawaz. I'm one of the specialty registrars at King's College Hospital, London, in liver transplant surgery. And the lecture is today is basically focused around liver and transplant. So, so the topics which I have divided for today are liver trauma, liver lesions, hepatic abscesses, transplant. In transplant? What are the type of donors? Disease donors. Either they are brain dead or who undergo donation after circulatory death. Living donors. In MRCs, I've seen it's a very basic question. Is mainly for people who are in critical care. Um, Trainees, but it also applies to surgeons, especially transplant surgeons. What is brainstem death testing and immunosuppression? So whatever I will tell you today is what we do on the field, what we do practically. Is not from the books. It is according to some guidelines and what we do on the field. When a patient comes, how will you manage those? And what I've seen, the questions are designed by the people who are specialists, and they will put a question um, what we encounter in everyday life according to different scenarios. And for people who are MRCSI, attempting MRCSI, I think they are either fresh graduates, they are interns, are doing house jobs, doing F1, F2, because they haven't been through these scenarios in real life. So it can be a bit tricky. So I'll just tell you what we have to do on the field, what is actually practically required. It's not from the books, it's according to guidelines and what we do on the field. Different hospitals may have different protocols, but uh, I will try to summarize it in a general way so that you are able to understand. The first is liver trauma. So, liver trauma is important. It's the second most solid organ which get injured in any blunt trauma abdomen after spleen. And because liver, is protected by the right rib cage, and it needs a lot of force for it to be damaged. Mechanism of injury is very important. So whenever a patient comes of any trauma, as every one of us know, that we have to follow the resuscitation protocol as per advanced trauma life support protocol, which we call this ATLS. So we have to assess the patient by A, B, C, D, E, and we have to resuscitate the patient and reassess at every point. and see the response of the patient, whether this patient is responding to a resuscitation or not. So as we say that during primary survey, if a patient is responding to resuscitation, especially for the liver trauma case, these people are usually hypotensive, bleeding intra-abdominally, they have tachycardia. So if we give them fluid challenges like crystalloid, some places blood, so if they are responding and they are sustaining that response, then we classify them, they are stable in terms of what we need to do further with regards to imaging. So if a patient is stable, we will usually take them to CT. If they have responded to resuscitation, we have reassessed them and they are sustaining this response adequately, and we can buy a time to take the patient to CT. Usually we do a trauma CT, which is called pan body CT, head and neck, chest, abdomen, pelvis, and then we assess where is the injury. And in regards to the liver, we always divide the liver injury, especially the blunt trauma, according to American Association Surgery for Trauma. So these are the grades of the liver injury. If you go through this slide, it's quite interesting in a way that it has classified the injury according to the percentage of hematoma, parenchyma involvement, or any free blood. So I would advise you, as for MRCSA, because it's a theoretical exam, and some places in FRCS they ask this as well. So can you please go through this slide very thoroughly and try to memorize it? And we can just see if there is any point where there is any free blood in the abdomen, it will be regarded as grade 4 injury. Rest according to the hematoma size, parenchyma involvement, laceration. Grade 5 injury is the one where the total parenchymal disruption and there is hepatic venous injury, avulsion from the IVC. So going back to the previous slide, so after a patient of liver injury has come, we have resuscitated them as per ATLS. We have assessed whether they have sustain the response of resuscitation and they are stable, then we will take them to CT to assess the grade of the injury, which I have told you about, American Association of Surgery for Trauma. This is particularly applicable to blunt trauma rather than penetrating trauma. But as I told you, as an MRCSA, is important to memorize it. It will help you. The second thing, what we need to know that the patient is stable. We had done a trauma CT, and in trauma CT that we have found that they have this grade of injury. Then we assess the patient whether they are stable even after CT or not, how much blood they have in their abdomen, how much hemoglobin have they dropped. Usually now if for a patient who is by grade 3, who is stable, has sustained the response, the management is conservative. We usually admit them in high dependency unit for hourly monitoring. We do their serial hemoglobin with arterial blood gas, and then we assess them every hour under trauma team in the high dependency unit. Usually these people tend to stop bleeding, but if any point they become unstable, rather than waiting for another CT, resuscitate them and take them to theatre. There will be another scenario in which the patient is very unstable. You have come in accident and emergency, you have resuscitated them, try to resuscitate them, but they are not responding at all. In that case, you have to take that patient to theatre. Now, every hospital in UK has a trauma theatre. There is a trauma surgeon available. There is trauma team, including anesthetist. They have blood products available. So what you need to do as a surgeon, when you go for an unstable patient who has likely liver injury and has massive hemorrhage intraperitoneally, the first thing you have to adopt is called damage control approach. You cannot just go and start stitching the liver. First, you have to do midline laparotomy, open them fully. pack all the four quadrants: right, left, um, right inferior, um, iliac fossa, pelvis, left iliac fossa. So four quadrant you have to pack, and then start removing the pack from the place of less bleeding, to see if there is no bleeding coming, and then you come to the right upper quadrant where you think his liver has injured. But be careful that as a surgeon you don't have to just rush in and thrust the pack inside. You have to be very meticulous and careful, because you can cause more damage uh, than um, than good. So if you see an open liver, fully lacerated open book liver, like I've seen shown you uh, in this slide, if there is anything grade 4, but this grading is based on city. But if we have opened the patient and this is a scenario in that case, or this is a scenario, there is nothing you can do as a general surgeon. If you are a transplant liver transplant surgeon or hepatobiliary surgeon, you can think of further thing. The first thing you have to do, if a liver is open like this, you just have to approximate it on the both lobes, right and left. It will settle a bleeding a bit, then pack at the upper upper dome of the liver near segment 6 and 7. Under the segment 6, if you try to pack a liver as a sandwich approach, the liver is sandwiched between the two packs, it will stop bleeding. The first thing you cannot do is to open a liver like this and start stitching. You will not be able to control it. There is something called Pringle maneuver, which we do mostly in liver resection and also in trauma surgery. That for liver trauma, that we go around the hilum through the foramen of Vincello. We put tape across it, and then it will decrease the bleeding a bit. But the first thing you have to do is to just approximate the liver, pack it in as a sandwich approach, tell the anesthetist to catch up with blood products and everything available in terms of crystallite, and make a patient stable. This is first thing you have to do, damage control. But be make sure in mind that you don't have to compress the liver too much, because you will cause ischemic compression. So there is a balance between two that you have to adopt. And as soon the patient has been bit stabilized, you just have to put a laparostomy, like a Bogota bag or a mesh, and to make them a bit more stable and send them to ITU. And the first thing you have to do is to call localized, whatever the local center for liver trauma, for hepatobiliary surgery, you have to call them and ask this patient to be either reviewed here, if someone can come here, or if the patient can be transferred over there. The first thing as general surgeon you have to do in any district general hospital is just to pack the patient. The first thing, even if I'm a even if I'm a liver transplant surgeon, if I get into this scenario, the first thing I will do is to approximate the liver and pack it in a sandwich manner and wait for the patient to get stabilized. So once the patient has been in ITU, after this, you can redo a CT to assess if there is any area of bleeding. You can call for interventional radiologist to see if there is any active bleeding. They can embolize. The other thing you can do in any trauma setting, if you've done a CT scan, patient is stable, but there is an active bleeding, you can ask the intervention radiologist if they can embolize that area. Sometimes it is successful to embolize the hepatic artery or a branch of hepatic artery. But sometimes you have to consider laparotomy in these patients, because there is a lot of blood in the abdomen, and then you have to go back and to essentially decompress the abdomen. Otherwise, they will develop abdominal compartment syndrome. So as a surgeon, as I told you, ATLS resuscitation reassess if the patient is responding. CT scan, what are the grades as per AAST. If the patient is not responding, you have to take to theatre, damage control, approximate the liver, close the book, and also pack it as a sandwich manner. Some patients who come to us after being packed, we open them because we have to remove packs in 24 to 48 hours. They have some periods of stability. In that case, when we go in, we just have to remove the packs. If there is any obvious bleeding, we try to stitch it. If not, then just usually they stop bleeding. If not, then you just have to repack them. Supposedly, if they have stopped bleeding, we remove the packs, we put 2 drains, close them, and later on they go to ITU. But because there is a cracked liver, either they can develop bile leak. Bile is like a corrosive to blood vessels. They can develop pseudoaneurysms in the future. So every patient of this, we usually scan them, CT scan them after 7 days to ensure there is no bile leak or no pseudoaneurysm. For that, we do a triple phase CT scan. We do a arterial phase, venous phase, and portal phase to see where is the bleeding from. So this is a summary of a liver trauma. If any question at any point, please let me know. The second. Tala, hello, Tala, can you hear me?
Yes, I can hear you.
Tala, can any of participants take a question, or they can take it in the end, or they're not allowed to?
No, they can type it in the chat and I'll let you know.
Okay, no problem. So this is the first topic I've told you about liver trauma. So responded, non-responded, CT scan, take to theater, damage control, pack them, and also if any patient with active bleeding but stable, and on CT scan they're like a grade 4 injury, but they're stable, we can ask intervention radiology for embolization. But we may have to consider laparotomy if there is a lot of blood, there is intra-abdominal hypertension, then we have to take them to theater to decompress them. So the second topic is about liver lesions. And these are the liver lesions. I have found this slide or this picture. I have just taken a picture and then put it here. So we categorize them as benign liver lesions. There are simple cysts, we call serous cyst, biliary hematoma, hemangioma, FNH, focal nodular hyperplasia, nodular regenerative hyperplasia, hepatocellular adenoma, and inflammatory lesions, which are called abscesses because of meningitis. And there are malignant focal lesions like hepatocellular carcinoma, cholangiocarcinoma. These are the primary liver tumor and metastasis. It can be from colorectal, it can be from breast, and some cirrhotic livers can give appearance of lesion liver like a regenerative nodule, dysplastic nodule, or hepatocellular carcinoma. Hepatocellular carcinoma can even happen in non-cirrhotic liver. So these are the liver lesions you have to remember. Just try to memorize this table, it will be enough. For any liver lesion, supposedly if a patient has an incidental liver lesion has been found on a CT scan, what happens is usually suppose if a patient has a CT scan for some reason, they found a lesion in the right lobe of the liver. The rest of the liver looks okay, but this patient may have past history of hepatitis B treated, and the patient has migrated from Philippines to UK. Like a scenario in that case, if I am a general surgeon in local hospital, the first thing I need to do is to ask the patient to come and see me and do some blood, especially tumor markers. So what are the tumor markers? What we do for the liver? It is according to the etiology for the cancer. The main thing I showed you in the last scan is these three. We do for HCC, which is alpha fetoprotein. We do for CA19-9 for cholangiocarcinoma. And for any metastasis, the most common is colorectal liver mets. So we do carcinoembryonic antigen CEA. So these are the things you have to do. The CT scan has already been done, or maybe they had an MRI which showed an incidental finding. The first thing you have to do is to refer a patient to local HPV team where they will do an MDM, multidisciplinary team meeting. In UK, there is a big emphasis on MDM. All the cancer specialties are MDM led. Even benign specialties are MDM led. So first thing you have to do is to make a diagnosis, which is incidental finding. Supposedly in this case, CT or MRI, tumor markers you have to do, and the patient should be referred to local MDM. Then it's an MDM decision to either characterize the lesion on the basis of radiology. They will see the images. They can characterize these images by specialist radiologists like liver radiologists. They can tell it is either cholangiocarcinoma, it is a hepatocellular carcinoma, is a colorectal liver mets, or some other metastasis. Or they may have to do another modality of of imaging. If a CT is done, MRI liver is quite helpful if they need to do. If still they are ambiguous, we have to consider the biopsy of the lesion. So once we have biopsied the lesion, it is usually percutaneous needle biopsy. If once we have biopsy the lesion, it will give us a confirmation of the diagnosis. And for any cancer, after the diagnosis, which can be either radiological, it can be with biopsy, and it has been complemented by tumor markers. The second thing you have to do is to further treat the patient. You have to stage the patient. The staging usually in liver lesions, which are cancer liver lesions, are CT, chest, abdomen, pelvis to see if there is no metastasis, what are the lymph nodes involved, or if sometime we have to do a PET scan to see if there are any lymph nodes which are positive in any other area. So this is a brief summary of liver lesions. Benign liver lesions, and the most common benign liver lesion is hemangioma, then hepatocellular adenoma. Adenoma is usually in female who they have a risk factor, or either they are obese or they are on oral contraceptive pills. And in men, they are also present in men, but in men they are more likely to transform into from adenoma into carcinoma. So we have to be a bit more aggressive in treatment of hepatocellular adenoma in men. I don't want to go into the detail. You have to know the basic. We will confirm the diagnosis with CT, MRI, complement with tumor markers. If ambiguous, we'll do a biopsy, which is percutaneous biopsy mostly, and we have to stage the patient. Local MDM, specialist MDM role is very important. You don't have to forget it. And then I will go to liver abscesses. And so any patient who has like I'll tell you has been having a GI upset, diarrhea, or abdominal pain, has developed some jaundice, right upper quadrant pain, and fever with rigor and chill, you have to be quite suspicious with cholangitis or liver abscesses. So for any patient who come like this, you have, as in liver trauma patient, we will assess the patient as per ATLS. For any patient who is sick, septic, we have to treat their sepsis first. We have to resuscitate them. We have to give them fluid. We have to give them painkillers, and we have to follow a sepsis 6 protocol, sepsis 6 bundle. If you can Google sepsis 6 bundle, any patient for surgery, medicine become with sepsis, you have to follow sepsis 6 bundle. I will advise you to go Google and you can see it. There is something called Q SOFA, Q small capital, small q with SOFA, SOFA. It's a new definition for sepsis. So I will advise you to go through it as well. So any patient who present in sepsis, we have to treat the sepsis by resuscitation, give them antibiotic, measure their lectin, measure their urine output, broad spectrum antibiotics. And if you have a suspicion that this patient might have a liver abscess, you have to do a CT scan. So CT scan is very important. And then according to the CT scan, we can characterize them, either they are amoebic liver abscess or pyogenic liver abscesses. So pyogenic liver abscesses usually are on a background of a biliary abscess. Either there is cholangitis, or there is an obstruction in the biliary tract, or it has been spread through the portal vein from the GI tract. So we have to treat the sepsis. Through the CT, we assess the size of the abscess. We assess the locality of the abscess, which lobe is it, and where is the source, where is coming from. Most likely patient might have an appendicitis, diverticulitis. So this is very important. And amoebic liver abscess usually present with diarrhea, high-grade fever, which doesn't settle with normal antibiotics. So usually we can characterize them, ask the radiologist whether you think it's pyogenic or amoebic. It has a specialist characteristic. So this is a small slide, as I have told you. So we have to go through two things, mainly either these are pyogenic or non-pyogenic, which is amoebic. So pyogenic is complicated. The main thing you have to, any patient, you have to treat the sepsis, give them antibiotics or percutaneous drainage. and we have to speak to the radiologist, intervention radiologist, to put a percutaneous drain. Mostly all of the liver abscesses are amenable to percutaneous drainage. If they are not, then we have to do some open surgical intervention, but it is very rare. The other is, so the main thing for abscess is treat the sepsis, treat with antibiotics, see the response, if patient is responding or not. If it's a large liver abscess and causing persistent fever, patient not settling even with antibiotics, we have to ask for intervention radiology help. The second thing is, if we think it's an amoebic abscess, then percutaneous drainage is not very well advised because they usually don't settle easily. The first thing, you have to give them metronidazole to see the response. If they are not settling, then we can ask for percutaneous aspiration rather than draining, and then see the response. So main thing is to treat the sepsis, treat the source with antibiotics, and look for percutaneous drainage. So this is what you have to remember for liver abscesses. You don't have to go through much detail. So, Tala, any questions so far?
Not yet. There are no questions yet.
Okay, no problem. So that's fine. So, so I will go to my specialty, which is solid organ transplant. My specialty is liver transplant, and the solid organ abdominal transplants are mainly liver, pancreas, kidneys. Pancreas are usually simultaneously, um, pancreas kidney transplant, sometimes pancreas after kidney transplant or islet cell transplant. I will briefly go through these. It's important for any surgical specialist to know. Um, so, so the main thing is, what are the type of donors? So when we do the transplant, we have to have a donor pool. We have to have a pool of donors from which we can take the organ. So so we divide the donors into either diseased donor, either they are diseased donor after donation after brain death, that they have some um, uh, I will tell you, traumatic brain injury because of road traffic accident, and they have dropped their GCS. They have been brought into hospital, but once they are in the hospital, and they have been assessed neurologically, but their pupil or fixed or dilated, they have lost all of their reflexes, and their respiratory center is not working. In that case, we think this patient might have a brainstem death because of high intracranial pressure. You have to read about Cushing reflex, in which initially there is a rise of blood pressure. There is bradycardia because there is compression on the circulatory center. So you have to read about it. Cushing reflex is an important physiology question. So there is increase in intracranial pressure. They have and increase intracranial pressure leads to um, tonsillar herniation and compression on the respiratory center. So patient would lose all their reflexes. Their GCS is 3. They don't have any cranial reflexes, and they cannot maintain their non-respiration. So they have to be intubated and ventilated to give to make their body physiology to go as it was before. So this is called donation after brain death or brain death. Then there is called donation after circulatory death. This patient usually don't have irreversible brain damage, but they have brain damage to the extent that even if we keep them alive, they will always be in a vegetative state. So after discussion with the family, they are on ventilatory support, they are on cardiac support. We tell them that this ITU management is futile after discussion with the family, and then we think of withdrawing the treatment. All the treatments like ventilation, any cardiac support. So this is called and when we wait for the patient to develop cardiac arrest, the first patient is brain death. It has been declared dead by brain death and brainstem death testing. The second patient has some brain damage, but they are unlikely to recover. So we have to, after discussion with the family, um, all the supportive measures will be stopped, and it will be waited whether the patient heart stops or not. If a patient heart stops in certain time, then we will proceed the donation. It is quite quick procedure. We call it as DCD retrieval, and that we very quickly retrieve their organs like liver, even heart, lungs, kidneys, pancreas. And the other one is the living donation, which is more common in East because the cadaveric disease donation programs are not very well established. So kidney has been happening in Pakistan, India, but recently India has led a lot on liver donation and living donor liver transplant. Pakistan as well is happening more common in Korea, Japan. So these are the leading nations now for Turkey for living donor liver transplant. So the organs which we can retrieve from the living donors are liver, which is left side of the liver or left lateral segment, or the right lobe of the liver, or the kidney. So this question is very commonly asked in MRCS-A, MRCS-B, FRCS-A, FRCS-B. Very, very commonly asked. So you have to read it from somewhere. So brainstem death testing is usually for a patient who has as I told you, irreversible brain damage, who has lost the reflexes and not able to maintain their respiration. So we have to do a test called brainstem death test. So brainstem death test in UK has to be done by two clinicians at two different times. The two clinicians, one has to be a consultant, the second one can be a registrar or a doctor who has GMC for at least 5 years, and they should not be a part of a retrieval team or a transplant team. So that's very important. I will advise you, as I told you about advanced association of trauma for surgery, AAST guidelines for liver trauma. I will request you to read this as well from somewhere. So there are some prerequisites for brainstem death testing. The first prerequisite is that there should be a known diagnosis. There should be a known diagnosis in a way that you cannot just do a brainstem death on a patient who has developed irreversible brain damage because of unknown cause. It's very important to establish the cause. Either it is is traumatic brain injury, someone has attempted suicide, is hanging, which is called hypoxic brain injury, or they have bled, which is called intracranial hemorrhage. So this is very important. So they have to have a diagnosis. The other thing is there are some prerequisites that patient current state is not because of certain medication like sedatives, tranquilizers, alcohol, and they are not hypothermic, they are not hypoglycemic. So these things you have to rule out before we proceed to brainstem death testing. So after it has been established that there is a known cause, there are prerequisite has been filled that this patient state is not because of any reversible cause like hypothermia, like hypoglycemia, they are under the influence of alcohol, any sedative, and their electrolytes are normal. So once it has been established, then there is a second stage of brainstem death testing in which they will test all of the reflexes, cranial reflexes, which we call cornea reflex and pupillary eye reflex. They will check their accommodation reflex. They will do vestibulocochlear exam, gag reflex, cuff reflex. So these are important. So after the prerequisite has been filled, they have to do certain tests to establish cranial areflexia. So there should not be any cranial reflexes. After it has been established, patient is on ventilator, then they subject the patient to an apnea test. In apnea test, what they do, they pre-oxygenate the patient, and then they will turn off the ventilator for at least 5 minutes. And to see there is a rise of CO2, they will measure their blood sugar, blood gases, and they will see if there is a rise of partial pressure of carbon dioxide. If there is a rise of partial pressure of carbon dioxide to certain level, there is a cutoff. If you will read through, you will know. And patient will not have any breath taken during that apnea period. We call this apnea test. Then they will reconnect um, to the ventilator, and and the first, because all the requisite has been filled, they have cranial reflexia, apnea test has been established. So this will be the time of death for the patient. So usually the brainstem testing is done at 2 times. At the end of first test is a time of death. After that, they will give a patient um, some time for all the parameters to come back to normal. And after 30 to 40 minutes, they will do another test. So as I said to you, it has to be done by 2 people. One is a consultant and the other one who's an ITU consultant, the other one is a doctor who has a GMC at least 5 years, and they should not be part of any retrieval team or a transplant team. So this is important. It is very common question. So here you can be asked on Monroe Kelly doctrine principle, because skull is a solid, unyielding compartment in which there is compensation between two or three things like CSF, blood, and brain. So Monroe Kelly doctrine, what is cushioning, reflects what happened to a patient during brainstem death. Testing, what are prerequisite, cranial reflexia has been established, apnea test has been done, and death has been confirmed. This is a common question which comes, so you have to go through it. Becomes like bit irrelevant, but it is important. So this has been done. So next thing I will go, I don't want to go in detail. So these are the donation. I will go disease donor, donation after brain death, which I have explained to you, donation after circulatory death, in which the brain is not damaged completely, but any treatment would be futile. So with discussion with the family, all the treatment is withdrawn. So, so this is one thing. And the second is about immunosuppression. Just touch a brief about immunosuppression. The immunosuppression mainly is in solid organ transplant is based on three things. The first thing is called calcineurin inhibitor. So if you see here, the calcineurin inhibitors are tacrolimus or cyclosporin. So these are two. The main thing you have to know is about calcineurin inhibitors. They are nephrotoxic. They are nephrotoxic and neurotoxic. So this is very important. So tacrolimus is nephrotoxic as well as neurotoxic. Patient can develop kidney injury, acute kidney injury, chronic kidney disease, or they can develop seizures, neurological symptoms. Cyclosporin is, but the main regime for immunosuppression is tacrolimus. It is a very good immunosuppression, very, very good. So, but it has a low therapeutic index. It means it has to be in certain range for it to be affected. If it's below range, it won't be affected. It is above range, it will cause uh, complications or it will cause side effects. So any patient, maybe a patient, you are a general surgeon somewhere, come to you, had a kidney transplant and has come with seizures, has come with seizures. You medics have sent the patient to you because they don't think, because his kidney transplant has become developed seizures. So you have to check the tacrolimus level because they have maybe have any neurological symptoms. So that's very important. If a patient doesn't tolerate tacrolimus because of neurotoxicity, then we put them on cyclosporin, which is also a calcineurin inhibitor. But cyclosporin has its own side effects. And it is not very potent if we do put the patient on cyclosporine, they are more likely to develop rejection. The other thing which can happen with tacrolimus is, apart from neurotoxicity, nephrotoxicity, patient can develop diabetes. So we call is new onset diabetes, NODAT, new onset diabetes after transplant. So this is very important. And sometimes patients who are on cyclosporine for long term, they can develop gingival hyperplasia. So this is also important. So main immunosuppression drug are calcineurin inhibitor, which are tacrolimus and cyclosporine. Just memorize their side effect. Tacrolimus called nephrotoxicity, neurotoxicity. Cyclosporine mainly cause nephrotoxicity, less likely to cause neurotoxicity. Tacrolimus can cause NODAT, new onset diabetes after transplant, and cyclosporine long term can develop gingival hyperplasia. The other immunosuppression which we give to mostly to the patients are prednisolone steroids. And as you know, steroids can have a lot of side effects. They can develop diabetes, hypertension, um, fat distribution is not abnormal with central obesity, osteoporosis. So long-term patients who are on prednisolone or a steroid immunosuppressant, or any autoimmune patient who are on steroids, we have to be very careful about their bone health. So this is also important. So they should be getting DEXA scan, bone scan frequently. So this is one thing you have to memorize. Their blood pressures are usually high, their skin is very friable, they are hypertensive. Suppose a patient who is on prednisolone for long term has come to you with acute abdomen, okay, and you have to resuscitate the patient, but at the same time you have to keep in consideration that they have been on long-term prednisolone. So if you will stop the prednisolone, they can develop Addisonian crisis. So you have to start them on hydrocortisone. So this is thing you as F1, F2 in turn, you have to keep it in mind how to play with it. So if any question, you can always ask local transplant team. The other agent we use for immunosuppressions are called mycophenolate or azathioprine. So just remember, mycophenolate can cause GI upset, vomiting, diarrhea. Azathioprine can cause cytopenia, leukopenia. So supposedly a patient is on azathioprine post-transplant has come, but their and their white cell counts are very low. So you have to make sure you inform the local transplant team. So that's it for now. If there is any question, let me know. I will be grateful. Any question you can ask me now. Tala, can you let them ask direct questions?
Yeah, they can ask. If they want to ask any question, they can write in the chat. They can speak up now as the lecture is over. So that should not be a problem.
Okay. I'm not sure. Okay.
So basically, before the lecture, I didn't know anything about the liver or the transplant. But now, if someone would like to have a discussion with me, I would answer most of the questions. It was a very simple yet thorough presentation.
Okay, thank you.
So, guys, any question?
So through this platform, I just want to announce one thing. So hopefully, all the best to all of you for MRCSA. I'm sure these people are here for this series of lectures for MRCSA preparation. I do MRCS-B course, which is face-to-face and hybrid course. In Pakistan, I have been doing it. My wife, we have been doing for last 4 years with very good outcomes. And in Pakistan now, because the exam MRCS-B has started in Islamabad and in Lahore. So what I'm going to do is to start a hybrid course from September in Pakistan, in Lahore. Or maybe I will do Karachi, Pakistan, and Islamabad in September. Exam is likely to happen in October or November in Pakistan. So I'm going to launch a website shortly in about a week's time, where people can come and book the course. And I am, if any question at any time, they can ask me. I can leave my email here.
Yeah. You can leave it on
Any
the
question about the course for future, you can ask me. Hopefully, all of you pass, and hopefully, I get to teach you one more time
Yeah,
in
sure.
RCSB, which will be very helpful. I strongly advise you. Many people in Pakistan, India, Bangladesh, because we are not exposed to the system in UK. This exam is all UK based. Once you have work in UK or Ireland, you can pass through this exam very easily. But if you are in other state, it's difficult, like Sudan, anywhere else, Egypt, unless you have gone through the system. So I would strongly advise you, if anything, you want a help for. My website haven't been launched yet, but hopefully it will be. But I can put this is my website. It hasn't been launched. It's like a dummy website at the moment. I have asked one web designer. I have to just make some changes. Hopefully in a week's time, people should be able to book. If any problem, let me know. I will be happy to help.
Oh yeah, thank you for your time, and
No problem.
good night, because I know you're going to sleep
Oh
after
no,
this
that's
lecture.
fine. That's fine. It's okay. It was
Thank
okay.
you.
But it's
Thank you so
nice
much.
to teach. I would rather have a lecture where I would have can see the faces. That's very
Ah,
important.
yes. Yeah.
Otherwise, you think you're talking to yourself, and that's why I'm big. I'm more of face to face rather than this.
All
But
right.
it was good.
All right.
I can share the slides. You have my slides. If
Yeah, I
anyone,
have. I can send it to them
no
via the
problem.
emails. No
No
problem at
problem.
all. Okay.
Okay.
Thank you.
Thank you
Thank
very
you for
much,
your time.
everyone.
Thank you.
Okay. Allah Hafiz. Assalamu alaikum.
Allah. Bye. Thank you.
No problem.